Odisha State Branch, Bargarh. Dr. Arakita Swai, sir, Dean and Principal of IMS Campus 2, Fulnakhara. Dr. Mamta Devi Mahanti, Professor and Head of Department of Pediatrics, IMS and Some Hospital, Bhubaneswar. Thank you.
Good morning, one and all. Most welcome to this session. And in the beginning, on behalf of the chairpersons, I thank the organizer for choosing us to be chairing the session. And I, on behalf of chairperson, also invite all of you to this first session, transition care. And as you know, any transitional phase is definitely bad, very unpalatable, and it needs smooth handling. So also pediatric rheumatology. So the child becomes affected by rheumatology conditions and ultimately becomes chronic and goes to adulthoodness. And this needs smooth transition. And before that, I will be preparing the stage, then going for proper transfer and ending in the adult stage, or mid-20s. And this flight needs really good uptake, then go for travel and happy and safe landing. So let us learn from the great panelist, one Dr. Pradipta in between two Jyotis, and the moderator being none other than Dr. Suma Balan. I welcome Dr. Suma Balan to take the stage and go for the event. Thank you. And only warning, please stick to time. Thank you.
Thank you, sir, for the very kind introduction. Can I welcome my panelists on the stage? Dr. Pradipta Patro, he is the head of rheumatology at Some Hospital in Bhubaneswar. Dr. Jyoti Randan Parida is a consultant rheumatologist in OARC clinic. Okay, I think you can see me now. I have transitioned to adult size. Okay. And my third panelist is my lovely friend Jyoti Raghuram from Bangalore. She's a pediatric rheumatologist in Bangalore. So you can see my cover slide itself is a transition process from pediatrics to adult. So what is transition? Is it a simple baton transfer that we see in a relay race? If we just said, okay, now 18, next time you go there, things will fall apart. So, why transition? Jyoti, why transition?
So, as we all know, rheumatological illnesses are chronic and continue well into adulthood. Many of them start in childhood, and as we continue to handhold them, at some stage we have to start talking about transition and ensure that a successful transition is made so that the care continues with the adult rheumatologist, and the needs are different after a certain age, which we as pediatric rheumatologists are not really equipped to handle as well as the adult rheumatologist. So as we, in childhood, when we look into their vaccinations, their growth, their mental health, along with the care of the illness, as they become adults, their needs change, and hence we have to ensure a very smooth and successful transition. Marriage, pregnancy, other lifestyle diseases like obesity, hypertension, diabetes mellitus, all these will have to be handled along with the treatment of the illness.
That is so true. I mean, I remember there was this girl, very difficult lupus she had, managed her, she did very well, very bright student, finished her class 12. The day she finished her class 12 exams, she ran away with unapproved boyfriend, and she went to his house against her parents' wishes. Her dad disowned her, Her mother didn't know what to do. She was distraught. They never saw her after that. One day, she landed up in my OPD about 9 months later and visibly pregnant. I don't know who was more scared than I'm not managing. I called Mithun, I screamed, and I took her into my colleague's room, and that was not the ideal transition, but that's how it happened. So, what is special about the transition period, Dr. Jyoti?
Already we are discussing the transition, why this is so important, because these are long-term diseases, and these are people who start at a very early age, you have rightly told about juvenile lupus. And initial phase, it is more about how to manage the disease activity, how to manage the nephritis and everything. But during this period, what we call as adolescent and young adults, like from 12 to 18, actually this is a very gray zone actually, because we are very comfortable after 18. You are very comfortable before 12. But 12 to 16, because everything changes actually. From the patient perspective, because before 12, patient is a passive patient, usually brought by the parents to the clinic. They don't have any say in the treatment process. But as you have told, by the time they get 10th class, 10th standard or 12th, they start thinking about the disease. A whole lot of psychosocial burden is on them. They feel like they are different from their friends. They are not able to have fun in life as their friends are doing. And I think they need to have shared decision making. I think that is very important for why we need at that time. And everything is evolving psychologically. They are getting maybe having this connections with other, like you have told, boyfriend and girlfriend, whatever. They are getting attraction towards the opposite gender. Sometimes even there are unwanted pregnancy, like you have already highlighted. So all those very fastly changing mindset and the treatment process, and a pediatric rheumatologist is very comfortable in taking care of their domain, like vaccination, how to manage with minimum steroid, how to avoid this growth retardation. And the adult is very much compatible with other aspects, like how to manage complications, how to collaborate with other colleagues, like if somebody needs collaborative effort. So, but this mid-zone, like 12 to 18, I can tell, is somewhere it has to be seen by both adult and pediatric rheumatology, because no one has actually specialization on this during this age.
Thank you, Dr. Jyoti. And if you can see the facts I've put here, the risk of this age group is also the mental makeup of these patients are such that they have a high risk of flare. That's another reason why we professionals need to take that additional responsibility to make the transition smooth. So, Dr. Pradipta, can you tell me how the perspectives change between the adult specialist and the pediatric specialist? And yes, how, you know, we already know that there are existing, countries have got set systems on how we transition, and they have got, proper systems in place. We don't have that. We have to create it. We have to do it ourselves. So, in fact, in India, the only Indian article I've seen is on this one, written by Dr. Molly Thaba and her colleagues 15 years back, and this article actually dwelt on the need for adolescent rheumatology to be evolved, because that is an area where this was a time when there were hardly any pediatric rheumatologists in the country, and they felt that the adolescents with rheumatological disorders were being under-managed and not given adequate support in general. So, consultative styles and experience, Dr. Pradipta, how would you think it would differ between the adult clinic and the pediatric clinic? We'll go with the adult first.
Okay. So, like they are telling, less than 25 years, the frontal lobe is not fully developed. So that is why the pediatric populations mostly their medication dependent upon the parents. We educate parents to give the medication to the child. When the adults come, we are telling directly to the patient that you have to take the medication regularly. So irregularity medicine should be addressed at the same point of time. Second things, like transition should be done by when the child is in remission. It's not in the disease flare time. Otherwise, there will be no trust in between the adult rheumatologist with the patients, because whenever there should be disease remission should be there, and there should be joint clinic like with the pediatric rheumatologist with the adult rheumatologist. And like in pediatric, mostly like adult, they are quite hurried. And pediatric, they think like we are good with our pediatric rheumatologist. And in Western literature, they have seen that 50% of loss to follow when there is transition from pediatric to adult rheumatologist. So in India also same things are there. So it is everywhere, like transition is very much crucial, and we have to address jointly, and there should be some transferring letter, and there should be some communication between the pediatric rheumatologist with the adult rheumatologist that this patient is this, what happened over how long, and along with the whole history, social, personal history, everything should be disclosed. And this pediatric rheumatologist should tell that patient that this is our adult colleague, they can take care of so that the confidence and faith will develop on the patients with the adult rheumatologist.
Absolutely. Jyoti, tell us about the style of the ped room clinic, how the patients are treated as opposed to what they should expect when they go to an adult rheumatology clinic.
This, our pediatric rheumatology audience is very familiar with this, because we see the family as a whole, not just treat the child. We are talking to the parents mostly, and we also speak to the child. And the time taken for seeing one patient is long. We take a detailed history, the psychosocial history, the family history. We and have to explain to the parents who are very anxious and concerned whether how long is this disease going to last, how long does my child have to take treatment, the side effects of the drugs, especially glucocorticoids in a growing child, and the trauma of taking the child very frequently for blood tests, for hospital admissions. So it's all very traumatic. We develop a strong rapport with the family. We see the child periodically, and we actually become more like a family friend, I can say, who will actually, and the parents want to continue care even after the child is an adolescent, and they ask, oh, should we change? But why should we change? So all this has to be they have to be taken through this process over a few years. And so this would be the difference between a pediatric rheumatology setting. With adults, like Dr. Pradipta said, they are capable of articulating for themselves what they are experiencing, and so it would be different.
So our patients actually need to be told that, we need to expect them to start developing independence, coming by themselves. That is always a big thing. They're not coming with their parents, they're coming by themselves. They have to get their tests done, they have to collect their drugs, they have to know their doses, they have to know everything. There's so much independence involved. And I think if pediatricians, we are too nice to a fault, we handhold a bit too much, and that independence is expected. We also have to create the process for that, and that is what transition is all about. In the West, they actually, these are all various systems that exist across the world. It's with our kind of numbers and busy clinics, it's very difficult for us to imitate and create the same system going forward here. But they actually have transition toolkits and questionnaires where they assess readiness, and then only they transition the patient. It's a process. There are combined clinics where they are seen together with the adult and the pediatric rheumatologist, and then they are kind of let loose alone in that world. So there are different ways, they've got, and the role of nurse practitioners helps tremendously in facilitating this process in the West. As you can see, they've got, it's a objectively laid out system, and they assess the patient's capability. And in UK, it's called from the pond into the sea, where they have similar kind of techniques to transition patients. So they assess them. The adolescent clinic is moved into a transition clinic. The transition clinic usually has both the adult rheumatologist and the pediatric rheumatologist sitting together. And then they have, the nurse practitioners have developed the checklist, the ready, steady, go. They see whether this patient is capable of being transitioned and then transition them. And even after transition is complete, they follow, the nurses keep an eye and make sure that they have attended their follow-ups, that they are in control of their lives. So they're not completely free. They're on telephone follow-up from the nurses for about 6 months after transition happens. But I think evolving systems like that, it would be very utopian for us with the kind of numbers we have. But what I thought, we'll make it more interesting. We'll look at some cases and we'll see what we need to do for transition readiness. So here's a 14-year-old girl. She was 14 when she developed lupus. She had lupus nephritis and neuropsychiatric lupus. She required steroids and cyclophosphamide for her treatment, and she's now on mycophenolate maintenance and hydroxychloroquine in remission. She's now 18 years old. She's in class 12. So, Jyoti, would you plan transition now? What initial steps would you take? When, where, how?
Yeah, so definitely we need to plan transition. In fact, the process would have started a couple of years before, and this is the time when we should be actively transitioning the child to adult rheumatologist with about maybe a 6 to 12 months overlap period of follow-up with both pediatric room and adult room. I've had the privilege of practicing in a corporate setup and also being associated with a pediatric rheumatology clinic in a government hospital. So what we see are differences is, in a corporate setup, if you have the luxury of having an adult rheumatologist, it is easy to just pick up the phone and talk to them and tell them, or even have a joint consultation with the adult rheumatologist. It would be ideal if both can see the family together and counsel them about how the care would be taken forward. But many a times that is not possible. And I've also seen those children who come from far and wide to a government hospital pediatric rheumatology OPD are very hesitant to understand, to move to a different doctor. And we sometimes continue to see them for another 6 or 12 months more till they are comfortable. And so it would be a resource available and how the setting is. But it should be a detailed medical summary should be given. We have to ensure that the child's vaccinations are up to date, the latest reports, and like Dr. Jyoti said very appropriately, the child should be in remission when we are planning a transition. So, and I would talk to the adult rheumatologist and give them a detailed medical summary if possible, and a letter should be given to the family and the child, and details of whom they need to meet and when.
Thank you, Jyoti. Dr. Jyoti Randan, could you tell us what information you want from Jyoti?
So before going that, let me make it very clear that referral is different from transition. Like, it is not like that you will refer to any, like SCB Medical College or AIMS Bhubaneswar or somewhere else. Because if, like you have already told, if the patient is handled with a pediatric rheumatologist for a quiet period, what he or she needs is, if he is going to another physician, first of all, there should be interaction between the two physicians. Then the same physician has to see him or her repeatedly. Because if every visit in the adult clinic, he will meet new doctors, then I think that faith and everything, that trust will go, and he will not take the treatment process very seriously. And number two is, what information we need is, from the date of diagnosis, that how this diagnosis was made, which organs were actually affected, what is the serology like, what is the antiphospholipid antibody status, what is the lupus anticoagulant status, everything we need. Next is, what is the steroid dosing, like when the patient has flared, when the steroid has gone below 5 milligram or 2.5 milligram. Because all these things matter in deciding that how fast or how slow we can go in tapering the steroid and other things. A good thing that the patient is in remission, so this is the perfect time. The other things is vaccination, that which vaccines patient has received, whether the patient has received, if it is a young girl, so it is all about cervical cancer vaccine or HPV vaccine also, that comes into picture. And next is, what are the practices and belief of the patient? Like, because the pediatric rheumatology already spent quite some time, so what is their belief, like they want to take medication, they want to take injection, or they want to frequently go to Google and ask questions. I think all those, even if it looks silly, but I think these are very, very informative things that should have transport to the adult rheumatologist to make our life easy.
Thank you. And also the cumulative dose of cyclophosphamide has to be
Cumulative
mentioned.
dose of cyclophosphamide.
That's an important information that he needs. Okay. Now, Pradeep, a patient diagnosed age 13 with ERA-JIA initially had peripheral enthesitis and knee arthritis, is HLA-B27. At 17, he's evolved to sacroiliitis, and he started on tofacitinib with good response. Now, I think, Jyoti, a very quick thing on when and how would you plan transition, and Pradeepta, what difficulties do you see forward for this patient?
So we have seeing him as an adolescent, and while we will initiate treatment and continue to follow up regularly, I think by 15, 16, we should at least sensitize the family. And by 17, 18 is definitely the ideal time for transition. We know that ERA behaves differently in childhood. It's more of a peripheral arthritis, and the axial involvement is not so common. Whereas as they move into adulthood, the disease may take on a different form and involve the sacroiliac joints. So our sulfasalazine or may not actually work for the axial involvement. So if we have started him on tofacitinib, then we still need to counsel the family about what is the expected response, and the JAK inhibitor workup should have been done to rule out tuberculosis, and also tell them that sometimes may need a change of medication if this medicine does not help. And so it would be 17, 18, and till maybe we would continue to see him till 18, and then over a period of 6 to 12 months, see jointly with the adult room, and then we can ensure a transition.
So now this crucial stage, because संगत का असर आ जाता है इस समय, तो this, because you know this smoking is a very much harmful effect on this sacroiliitis and bone formation. So you have to sensitize them, don't fall in the trap. So make good habits and do regular exercise. Now we have to focus on more of sports. They can join the sports, whatever sport they want to play, and this smokings, good habits and regular medication, that makes them more comfortable. And in future, if this patient goes good in remission, we can taper up the dose. And here the pediatrician, when they think like any single joint got inflamed intra-articular, they are scared of. But in adults, we give, usually we give intra-articular steroid without any sedation or anything like that. So that is the crucial stage we want to take it. And regular exercise and compliance with the medication, that we will counsel to the patients.
Excellent, yeah. The change in style for injections is very important. So this is another interesting thing. These are all real life patients. A 17-and-a-half-year-old girl is evaluated in my OPD. She has fever of unknown origin, cough, loss of weight, and she's just completed her 12 standard exams. In that process of time, she's been unwell, and we also make a diagnosis as GPA. She has lung and upper respiratory tract involvement, GPA. So the question really here is, what is the right thing to do with this patient? I just want very quick answer, Jyoti. who should we transition this patient right now, or should we start treating the GPA and then make a transition?
An adult almost, and this is a newly diagnosed GPA. So it would be ideal to directly start treatment under the adult rheumatologist. Only if it's really not possible, then, and if there's an emergency, then we'll have to see if we have to do something before we start the transition.
Totally agree, because this is already newly diagnosed, and GPA is such a bad disease. It can be life-threatening at some time. So it is better that patient should feel that the adult rheumatologist is the person to start the treatment, because already 17. And so that you can have the full track on the treatment process. And here there are very important issues like you have to tell the patient first is prognostication, that if you will not get the treatment in the initial 6 months, then the disease is going to be a very bad effect. And that regular visits, initial prompt starting of the treatment, like either methylprednisolone, depending on the patient, or you are planning to start either rituximab will be a better choice, because 17-year-old girl. And then continuous follow-up with the patient, because first 6 months is very crucial for this patient. So I think straight away the patient can be sent to the adult rheumatologist without any transition, and the patient should take the adult rheumatologist as the practicing as his caretaker, so that the treatment process can be eased out and follow-up can be done.
Absolutely right, and this is exactly what we did. They might as well form that relationship with the person who's going to treat them for the longer period of time. Absolutely right. Now here is a case for very complex patient with SJIA, very early onset, had severe disease, was initially treated, was seen a bit later but treated aggressively, had a good improvement, but then slipped out of care and then comes back. All the good you did has been lost, but returns to your care at age 17 again with active SJIA, now an avian of the left hip. He has already lost 2 school years, so though he's 17, he's still in class 10. What do you think? We'll just stop with this case. So what do you think, Jyoti? Do you want to transition this child or not? And Pradeepta, do you agree with what she says?
Child, we will have to handhold for a little longer considering the history, and they may again be lost to follow-up if we transition forcefully. So it would we would have to stabilize, try to get him off steroids, restart the tocilizumab, and counsel them about the short stature, the deformity. He may need a hip replacement, and try to give career counseling options also. And maybe in a year or two, the child may be ready for transition.
Yeah, I completely agree, because this child is still in active GIA. He came with active GIA, so it should be taken care of by initially the pediatric removal. Once the remission occurs, then can be transferred to the adult rheumatologist.
So yes, so the age is not always the the cutoff for transition. Though 18 is roughly where we look at school. Basically, it's based on the transition from school to college. That's why 18 has been fixed in many places. But again, it depends on the child and how ready they are and whether things are right. I think we'll stop here. We've had this thing. I'd like very quick 30-second comment from each panelist. And these are 3 of my patients successfully transitioned, yet they still come back to see me just to say hi once in a while.
Gratifying, and when we see the patients who come back later with doing well in their studies, in their career, and are in remission or on minimal medication and are following up or sometimes even off everything, then it is really a successful transition, and the family is thankful and happy.
So as we have already discussed, transition is not shifting the responsibility. It is shifting the responsibility with responsibility. So I think with that, because these are long games, this is a test match, this is not a one-day 2020 match. So you have to play as a team to win the match.
Yes. So that patient should have confidence that like the pediatric rheumatologist, the adult rheumatologist also will take care of me. That trust should be built up between the two doctors so that patient will not lose the faith on the adult rheumatologist.
Well said and absolutely right. It's a team. We all have to play our part, and we have a greater role because we are the ones actively doing the transition. Thank you. Thank you to all my panelists. Thank you to the moderators.
Thank you, madam. Thank you, panelists. Actually, I'm very much involved in adolescent medicines. So it is for me, many questions are answered here. One question, madam, how often you are involved the adolescent during counseling about the disease and the course with parents?
We do, I mean, we are used to doing that. So we explain to them that this is a chronic disease, that this disease is going to be there with them for life, but the number of medicines they take now are not going to be necessary for life. We will bring that down. And the other thing I tell them is, you can aim for anything you want. You don't have, the whole idea of treating you is that we don't want to limit your life. Okay, you may have to take some medicines, you may need to have checkups, you may need to do other things, but you don't need to think that your life is gone or your options are gone or your ambitions are gone. You don't need to think that. The 3 cases I showed you, one is a boy who's a doctor now. The other one is a girl who was so sick, DAH, renal, NPSLE, everything, and she became a nurse, got married and came to see me. The third one is that girl who ran away, parents disowned her, and she thankfully, the boy stood by her, she came back with a baby. So, it's all up to how we win their trust and we help them believe that they can live well with their disease. And we all have a big role to play, not only us, the future professionals are going to meet. And we have to build their trust in them. Like what Dr. Pradeep sir said is absolutely true. We have a big role in building their trust towards the next profession.
Thanks, Dr. Suma Balan, for moderating this session. And thanks to all the panelists enlightening us that the transition care is a combined team effort of pediatric rheumatologists and adult rheumatologists, and it should be dealt with compassionate effort of both, and with a human touch and with a psychological support that is important. Thanks. So we are winding up this session now.